Good afternoon. So for our next talk, we are going to have a special honor of having Dr. Tim Mickiewicz, who's a dentist who practices sleep medicine. I look forward to having Dr. Mickiewicz discuss with you the dental appliances, the pros and cons, and who are the optimal patients for this type of therapy. Thank you, Dr. Mickiewicz.
I'd say it's a real honor to be invited to talk, and I notice there's a couple of other dentists in this room, which I think is really cool. So maybe you're aware or not, but there are two other dentists, at least that I know of, maybe more. So overview, we're going to talk about diagnosis, the type of appliances, what we expect, and what complications can be associated with the sleep appliances. What is our role? We look at the ASM guidelines, what our legal considerations are, what tools do we have at our disposal, and in our examination process. What is my role? We help to identify, and we're like one of the greater identifiers for the physicians because we see people, in terms of like the facial profile, for instance. Most common patients that I see either have very retrognathic, retruded jaws, or they have had 4 bicuspid extraction orthodontics, where they've taken some teeth out and they shoved everything back. And that's why you see kids now, we're expanding arches, we're trying to get tonsils and adenoids out. So please talk to your ENTs and encourage that when you see that facial profile, the adenoidal face with the droopy eyes and the retrognathic jaw. I know there's insurance rules, but those kids need their tonsils and adenoids out more often than not. So we're really good, but we don't diagnose. We encourage diagnosis, and that's our job. So we screen. We provide the oral appliances for people who fail CPAP, which is our most common population that comes to see me, that and primary snorers. But most primary snorers, I kick them back to their MD for not just financial reasons. Say, I don't care, I'll just write the check. But most of them fit the profile, and I want to get a PSG on them to make sure that I'm not missing something and I'm not doing something bad. So we monitor the appliances, obviously. So we look at the side effects, because there are some side effects, and we'll talk about those as we go along. You as physicians provide the diagnosis or the initial kick to the medical team. What our indications are: primary snoring, selected patients with OSA. Not everyone can be treated, obviously. People who are CPAP intolerant, which is probably 90% of my population that comes through the door. And, the surgery, I don't have to belabor the point, but it's not the most effective procedure. I know that the doc from Stanford talked about palatal stents and the UPPs, and there's some real issues with that. And I think the future will find that these people with the retrognathic profiles, we're going to see a lot more surgical maxillary mandibular advancements of the jaw. And that's where it's headed. So we fit the appliance, obviously we follow it up, and then we periodically evaluate the patient. Depends upon the medical group, how often we get to see them. And then when we're done, we need to do a follow-up sleep study. That's critical. Is it working? And people will come back, they'll report, yeah, I feel better, I sleep better, my wife doesn't complain, I don't have, bruises and bumps in my ribs because I'm getting elbowed by my wife now. You change lives. It's really cool. Not only do you add 5 to 10 years of good life to them, of quality life, but you get people who haven't slept in the same room for 14, 15 years. And, I feel like Dr. Phil sometimes, they cry, and I've saved more marriages. I should charge for marriage therapy too, but I can't. There's not a code for it, but I'm working on it. The legal perspective, obviously, we cannot diagnose sleep disorders. We do home studies. Dr. Brass reads them for us. We're trying to be pioneers in this area because we know it's probably going to be forced upon us in a period of time. And for follow-up studies, they're very efficacious. You've already ruled out, when they had the PSG, they ruled out all the wacky stuff he just talked about, all the parasomnias and the neurological disorders that they talked about earlier. But for the follow-up, it's like, okay, we know it's not a central apnea. We know it's obstructive. Is this appliance working? Is the CPAP working? And these home studies are amazingly effective if they're done properly and read properly, and they have to be read by a physician. So some of it falls, it's a very gray area, and like I said, I've been doing this for a long time. It started with treating TMD patients. I would see a lot of these patients, and part of my protocol, and we'll go over them as we get through the slides, is doing cone beam CTs on people. So we were seeing, as we're seeing the TMD patients, they'd come in, they're similar profile, retrognathic, class 2, 4 bicuspid extraction, and we get a sagittal cut of their face, and we look at their airway, and they've got like a 1 millimeter airway. And just for fun, pass this around. This is a before and after of someone who's been wearing an oral appliance. This is like an actual airway where we took the cone beam. This is, you can see before. Hopefully, you can tell which one is the after. And it may not look that dramatic, but what we did is we took the cone beam CT. We do a volumetric study. Then they can take that and they make a CAD CAM out of it, just like they would do for knees and hips and all that other fun stuff. So we can do that for dentistry too. And you can see how thin it gets and how thin that airway is. And you can imagine what the struggle this poor woman, and you'll see pictures of her, she has a lot of issues, but you can see the struggle that she has. And we didn't make it wider anterior posteriorly, but mediolaterally, we had a huge effect on her. And she does beautifully with the appliance. So what goes around comes around. It's a team. I mean, I need you guys. I need the dentists. We all have to work together. You know, the old adage, if your only tool is a hammer, everything's a nail. So for the sleep people out there, and the primary care docs, the rheumatologists, the pulmonologists, who will say to the patient, studies show, you know, that CPAP's 100% effective, and yes, it is 100% effective as long as you wear it. And there's no doubt about it. I won't dispute that fact. But the compliance over 5 years is extremely low. And they show numbers of 60 to 70%. Oral appliances, we show numbers, in my office, we show numbers in the 90% range. We also show, if under 30 episodes, we can get them under 5, 90% of the time. That's pretty darn good. The studies that are published say 60 to 70%. In our office, we get 90. So anyway, we have our little diagnostic algorithms, do a medical history. We take casts, we take x-rays of their teeth. We got to make sure they have enough teeth to work with. The cephalometrics, I tend to use cone beam CT just because we have that technology here. Not every community has it. You know, I don't have one just because the technology changes so fast. And I've got like the greatest radiologist in the world. And why not use him? Because reading this, if you read this stuff, if you miss something, you're up a creek. Because, you know, we can pick up, you know, I can't tell you how many tumors and atheromas and bad things behind root canals we can see three-dimensionally that we didn't know existed. And it's to manipulate that data and to have him, you know, pick that stuff up, and some of the neurological things where they've done a surgical advancement or whatever, and there's a screw stuck into a nerve, and we can see that because we can flip it around and manipulate. So we do our patient exam. Do they have teeth? Obviously, we look at the midline. We want to make sure things don't change, and maybe in 5-10% of the cases they will change. So we take photographs on everybody, and we have study casts. And we look at how their bite is, and do they have any spaces between their teeth? It's a diastema. So some of the appliances have, there's a lot of appliances on the market. There's a lot of knockoffs out there. There's things on the internet, and patients, you know, they're desperate, so they'll go for it. We look at the angle classification, which means what's their bite, you know, and there's class 1, 2, 3. Class 1's normal. Class 2, their jaw is retruded. Class 3, they're Jay Leno, okay? So class 3 patients, very rare to have a class 3 patient with a sleep apnea problem because their jaw is way out there, but you do have them, and they're a bear to treat. They're a bear to fit a mask to. They're a bear to fit an oral appliance to, because I've got to pull their jaw forward, and they're already, you know, 10 millimeters anterior. So what they really need is to have their maxilla brought forward and their jaw put in better position, but that's pretty tough. Bruxism issues, one of the things to point out here, this is something that you can like really impress your dentist friends. That's what we call an abfraction right there. So this little cleaving where this person's obviously a clincher grinder. You can see the wear and tear on these teeth, all the attrition. But this little cleaving right at the gum line is classic for bruxers, and the tooth is actually flexing in the bone. And that's what creates that. It's not from brushing your teeth too hard. That's a total fallacy that has been perpetuated by dentists to this day. I have no idea why, because it's easier to explain that than it is to explain why an abfraction happens, and I'm not going to bore you with that. Okay, condition of the dentition. You got to have 10 teeth, and they got to be 10 good teeth. So obviously, you know, but as long as we have 10 teeth, we can actually make them on edentulous patients too. But we like to have teeth because they work better. A number one cause. This should be on the test. Everyone should know this. A number one cause of GERD is sleep apnea. A number one. People don't know that. And we see GERD all the time. We see, is this bulimic? Is it GERD? I mean, you can tell by the age of the patient, if they've got some crowns and whatnot. When you see this, and again, when you're doing a quick oral exam with a little tongue depressor, and you see this melting, but the tissue health is really like great. It's like, why are these teeth melted? I mean, it's like they're just like battery acid being poured in their teeth all day. So, and it has to do with the respiratory effort, working on the diaphragm, which opens up the esophageal sphincter, which allows the acids to come up, and hence you get the melting of the teeth. So you see that, it's like, red flag, maybe sleep apnea patient, and you'll be a hero, because they can't fix it. You keep throwing pills at them and Tums and all that stuff, and you're not really solving the problem. You're masking the problem. And it's not the only thing that causes it, but it is the number one causes. Patient exam, we look at the perio, look at the gums, are the teeth moving? And obviously we do an oral cancer screening on all of our patients, no matter what they come in for. This periodontal disease, pretty obvious. We want to get this cleaned up before we make an appliance. And it's just a good opportunity, when you see this kind of thing. A lot of controversy about links between periodontal disease and cardiac issues and type 2 diabetes. My personal opinion is if you are so bad about your oral hygiene that you look like that, you probably don't take care of yourself very well either. So I think the numbers are skewed a little bit in terms of the type 2 diabetes and the heart issues, even though they've put this direct correlation and connection. They say they've done these triple blind studies and whatever. Now they're they're backing off on that just a little bit. So obviously we look at that. With the jaw joints, that's critical. Measure range of motion, protrusion, all that other fun stuff. So we look at all these things, the size of the tongue, obviously. One thing that is not on this slide is looking at the size of the mandibular tori, which if they would remove a lot of those mandibular tori, we would solve a lot of sleep issues. Because where's the tongue supposed to go when you open their mouth and the tori are so big, these big lumps of bone that are on the lingual arch, and so big that they actually obliterate the floor of the mouth. So the tongue has no place to go, and they could be perfectly fit and healthy and not fit any other criteria, except that good luck convincing the insurance companies, if you just take the tori out, the CPAP doesn't work on them, the oral appliance isn't going to work on them, take the tori out and it'll work on it. And so go get the tori out. Okay, enlarged tongues, obviously that's a problem. Like, where's that tongue supposed to go? I mean, there's a lot of reasons, there could be medication reactions that can create that. There can be just structural issues, very narrow arches, like this person has a very narrow arch. Their upper arch never developed properly, so the tongue has no place to go when you see that cleft. Really long uvula hanging down there, loss of tonality of the palatal tissue. Scalloping on the side of the tongue. So when you look at this and you see the scalloping, this is classic. You look at these teeth and you can see how worn off they are. This is a classic clincher grinder. Just as soon as you see, look at the open mouth, stick the tongue out, and you see like this little scalloping on there because they're using their tongue as a splint. And so that, and they maybe have some tongue thrusting issues, but it's again, their tongue has nowhere to go, so oftentimes it'll fall back, which creates more of an obstruction. And you can try to blow it open with a CPAP, but you're not going to be very effective, which is why they end up in my chair. Get some orthodontics done and be amazed. Enlarged tonsils, again, I don't want to berate the point, but we don't take enough tonsils out. Enlarged palates and uvula, you see this daily, I'm sure. What do you do? I mean, you can't, the UPPP, I mean, it fails 50% of the time. Is that a good number, do you think? Somewhere in there? So, so over time, because especially if they don't change their body mass, then they're going to end up having, the same gravity issues taking hold, and eventually it'll reverse on you. Battered uvula, I will leave that to your imagination where that comes from. Obstructed airway. We see this. You see this. What are you supposed to do? I mean, they've got these monstrous tonsils. They've got this uvula that's about inch and a half long. No space in here. Probably they got scalloping in the tongue. This is a problem patient. It's a problem CPAP patient. It's a problem oral appliance patient. So we look at this and we don't promise the moon on these people because we'll do the best we can, but there's only so much we can do. So we do a lot of airway imaging. This is kind of this is the model that's being passed around there. This is a cone beam CT. We can get down to 0.125 millimeter slices with this technology. So we can find things that you just can't see otherwise. So we pick up sinus diseases. They're sent to me by their ENT oftentimes, most of the patients. And we find obliterated sinuses, obliteration of the osteomeatal complex, big sphenoid sinus issues. And so I'm kicking it back to the ENT like, of course the CPAP's not working. I mean, you're blowing into, a totally obliterated sinus, so it's not going to work. And the oral appliance isn't that effective either. I mean, because they're still going to want to be a mouth breather. So that's why I like that SomnoMed, because they can still open and close easy. The one with the flange is very effective, but the issue I've had with that has to do with the insurance companies are now mandating that we guarantee the appliances for 3 years. Where they come up with that number, I have no idea. SomnoMed, they do guarantee their appliance, they always have for 3 years. An Australian-based company, worldwide. There is another generation coming out soon that we're beta testing for them, actually. So anyway, so we do these nice cone beam studies, and we can slice and dice the sinuses, the airway space. We can see where the tongue mass is, obliterating this thing. We can slide this little gyroscopic thing up and down the airway to find out where the minimal airway space is. You can see this is a traditional cephalometric x-ray, which a lot of orthodontists would have, and they don't pick this up at all, which amazes me, but that's the airway right there. So that's the ones being passed around. It's this lady right here. But when we put the appliance in, this is her with the appliance out. This is her with the appliance in. So you can see we've taken no airway and we've created an airway, and she actually does pretty good. And it's mostly medial displacement that we're getting of the airway space, not so much anterior posterior. If she lost some weight, she'd be doing great. We look at it, but you can see the volumetric changes that we have. Sometimes it goes backwards. Sometimes it doesn't work very well for us. So historical perspective, it's been around. We've known about this stuff for a long time. This isn't like new to us. But in terms of the oral appliances, it really came about 15 years ago. And this has created a little bit of an issue for me because I signed a lot of contracts with all these medical groups to handle their TMD patients, and sleep didn't exist, at least the sleep appliances. The cone beam technology from even 5 years ago is like, it's just like fuzzography. It's worthless. So we've known about it because we didn't have the technology didn't exist, and so it's a baby science. So we're learning. How do they work? It's real simple. Basically, you pull the jaw forward, the tongue goes along for the ride because it's attached to your tongue, right? It has no other choice. It increases the tension of the soft palate, so the soft palate doesn't vibrate so much. It also pulls it forward so it doesn't collapse as much. That's how it works. In a nutshell, real simple. So when you increase the tension of the soft palate, there goes your snoring. Almost first day. I always say 2 days, under promise, over deliver kind of thing. I always say 2 days, your snoring will disappear in 2 days. And it's 99% of the time I'm right. It's usually 1 day though. And they come back, no, it's a 1 day. Gotcha. So we reposition the jaw. We stabilize the mandible and the hyoid. There's a study they did about the stimulation of the genioglossus muscle. Types of appliances, there's a boatload of them out there, okay? 3 different classifications: mandibular repositioning, the tongue retaining appliance, which is what started. That's what people use most often. You can get them pretty cheap, about $50, or combination appliances, which we very rarely use. So what's most important from our perspective, this is a tongue retaining device. Most of the tongue retaining devices, this one has tubes to hook up with a CPAP also. So tongue sticks in there. Most of the tongue retention devices is just this part here. You don't have that. So it's like this little bulb that sticks out, and no one wears them. Mandibular repositioners, here's the numbers. In terms of efficacy, they show 40 to 60. We're up in the 90% range. So there's non-adjustable appliances. This one, too much stuff. They're trying to create space. It's covering the whole palate. These clasps, that'll create the separation of the teeth. So that's an issue. This is the Hannibal Lecter appliance. This is, there's a little slot in this one that's Napa, but these are non-adjustable. So if you're not on the money with the bite, look how it's changing the bite, how big they're opening that mouth. Adjustable ones are where that's where the industry's going. This is a Herbst. This is coming back into favor. This is actually an old orthodontic appliance, which we're now using for sleep, and we've actually made dramatic improvements on this. It's got a little bar on the side, and now it used to be you had to put these little sleeves on, But now we've got like a little tool that we can crank it. So that's become a very popular appliance. Somehow Medicare has decided that all oral appliances have to be hinged. This is the only hinged appliance that's out there. I wear these appliances, so I know I have sleep apnea. So I try every single appliance. So I've worn this. I've worn the Somnomed. I've worn all the knockoffs, the cheap ones, the fixed ones. I've tried them all. This one, a variation of the theme of what we've got there. My favorite, Somnodent. We've got these little fins, and it's really easy adjustable, and it's nice and slick. And the deal is that we can titrate them very carefully. The Somnomed in 0.25 millimeter advancements. Somnomed has just come out with a new system, just got FDA approval, where for people who can't tolerate it, you do the PSG with this appliance, and it will slowly advance their mandible through the night, and so they can see the efficacy of the appliance as things are going on. Again, this Therasnor, you see this one, it's pretty cheap. This thing goes down on the lower arch and pulls the jaw forward, but not very titratable. This is one of these Clearway appliances. Where does the tongue go? We're trying to make room for the tongue. It's just like there's just no room. You got to think when they make these things. This guy dislikes his picture in every presentation I do. He wears this thing, which is from Australia. It's like a neoprene strap. It's a great chin strap, by the way. It's very comfortable. You can get them on the internet. And so instead of the ones that they tie around, it actually works pretty well for people with CPAP, want to keep their mouth closed. He wears this, CPAP, and oral appliance. So combination therapy, I've never made one of these. Very rare. But usually we make an oral appliance and they have the CPAP, like up in the 90s and 100 or whatever, and their pressure on their machine is at 18 or 19 centimeters. And then it's like, if we can get the oral appliance in there, then we can get the pressure down, which is nice. So what do we know? Weight loss, yes, obviously. This is where we're going to be looking at probably in the future. Changes in the airways before and after, pretty nice. Before, after, pretty nice. Not so nice. Went backwards. So this is the limitations of the machine, But look at the epiglottis. They're swallowing when they took this picture. So I'm like, take another picture. They're obviously swallowing. So there are limits. This is one of our patients. Classic. This is our, it's 52, 55 is the most common. Bulldog, jaw, big, heavyset guy. Grinds like a maniac. Look at these teeth. They're just all worn down, broken, bridges everywhere. And retrognathic profile. When the teeth are kicked back, he's also retrognathic. So before and after, you can see the volumetric changes. Before the appliance, down in here, when we slide this little thing down here, we were at 111, and we got him up to 280. So we almost tripled the size of his airway. Pretty good. This is more him. And like I say, this technology is great. We use to look for facial asymmetries and whatnot, because you can mess up a bite. That's the consequence. You can really jack someone's bite up bad. And so you better know what you're doing. So these people who are taking these weekend courses and thinking they're pros, a real problem. So the occlusal changes, the numbers, they're about right. I see more like 5-10%. And why? Because the posterior attachment apparatus gets thicker. The muscles adapt to a more forward position. And you ask people to bite down when they've been wearing an appliance for a long time. They'll bite down, they go edge to edge. And then you have tooth movement depending upon the type of the appliance. So what do we conclude? They work. Yes, they work. Why do we get TMJ problems? They probably had one to start with, so that's why we diagnose. Diagnose it first, inform before we perform. All right. Thank you so much. I wish I had another 2 hours.
Thank you very much, Dr.
Okay.
Mickiewicz.
All right.